The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Hello, Sky Women. We hosted our World Menopause Day event, Thriving Through the Pause, yesterday at Sky Women's Health. And it was such a beautiful reminder of why community matters. The conversations, the collaboration, and the curiosity were incredible. A true celebration of women supporting women through midlife and menopause. A huge thank you to our amazing collaborators who made the event so special. We had Jana Weaver with Radiant Nutrition. We had Dr. Tatiana Miller with RX for Life, who is a psychologist, a professor, a life coach, and a yoga instructor, and she led Yoga on the Lawn. We had Corey McGuire with Genesis PT and Wellness, one of my favorite pelvic floor physical therapists to refer to. Heather Chandler and the team from Vervewell Counseling, and Dr. Chelsea Angeloki, who's a psychiatrist and the founder of Centered Psychiatry. Each of these women brought such wisdom and warmth and expertise to the table. And of course, my team executed the vision perfectly. And I just couldn't be more thrilled. If you missed it, be on the lookout for our next event because it is just fabulous to be in community with women who understand what you're going through. Okay, one of our collaborators, Vervewell Counseling, joined us yesterday, and Heather Chandler gave an awesome presentation. And if you caught last week's podcast, you heard Beth Lewis, the founder of Vervewell, along with Heather. And they invited me on their podcast, This Won't Be Done by Five, season 3, episode 2, that's now streaming on YouTube. And we had the best time talking about the biopsychosocial aspects of sexual health and how mental health providers can better support women through that menopause transition. It was such a fun, rich conversation, such an important conversation. I'm excited to share it with you today.
I would love to kick off as we kind of have dialed in a little bit of a direction to head. I also wouldn't mind if you wouldn't mind telling us, Dr. Moyers, the reason for the title of your practice. I like the name Sky Women's Health, and there's a little bit of a message behind it. Would you kind of go into that for us?
Sure. Yeah. I really toyed with what to call it. But Sky Women's Health is named after the Chinese proverb, women hold up half the sky. And women do so much of the work. And I just believe that women deserve better. I believe that I deserve better as a physician, the kind of care that I wanted to provide for patients. And I read the book Half the Sky, which is a phenomenal read, especially if you nerd out on all things related to women's health like I do. And I was just floored and thought, oh my gosh, like the disservice to women. And it just really kind of changed the fiber of my being. And I thought this is what I'm going to name my practice, because women do hold up half the sky. And when women are functioning at their best, communities change, businesses change, families
Absolutely.
change,
Here, here. I agree. Yes. I love that. I love that so much. And that sparked a chord in me when I read that. And probably my first thought was, oh, they hold up more than half the sky. But
yeah.
we'll go with that. We'll go with that for now.
We'll go with that.
Equality and all of that. So I like it. And that's wonderful. So I think that today what we do have Dr. Carolyn Moyers from Sky Women's Health with us, and we're excited. We've worked with her before and had conversations with her before because we are of such a like mind when it comes to supporting women and when it comes to supporting the health of women. She definitely leans into the physical health of women, at the same time holds space for the emotional well-being of all of her patients. And we absolutely, as therapists, work with women who will benefit so much being in your care and your staff's care, because we also have such a heart and soul towards the support of women and their mental strength and their mental capacities, and being in their corner so that they can function at 100% and have a blast doing it. So we're really excited that you're here with us today, Dr. Moyers. And if you would kick us off a little, Heather and we talk a lot in our sessions. Heather and I both work with couples, and I work with couples, and very specifically, I work with couples, a lot of couples that are in my age group. I'm 55 and have gone through menopause, and have and work with couples having the conversation, and individual women, but having the conversation about where their emotional headspace is in this chapter of life, and who are they now versus who they used to be, and why is their sex life different. And these are the conversations that I love when my clients are bold enough and brave enough just to sit down and spill it, and we talk some really real talk about our bodies and our emotional headspace. So if you can kind of guide us into a conversation about the conversations Heather and I would be wise to hold for our clients, something that perhaps we haven't thought of, or that we're doing right and we need to do it more often. But if you could guide us and kick that off, that would be wonderful.
Glad to. And I love our working relationship. I love referring patients over to Vervewell as well, because at Sky Women's Health, we take a very comprehensive approach. It's the mind, the body, the spirit. It all is interconnected. And when it comes to sexual health, especially for women, it is this biopsychosocial approach. It's never one-sided. It's never just one thing. However, I do find that if I fix the genitourinary symptoms of menopause, if I fix that dry, painful vagina, a lot of times the sex drive returns.
Nice
So
to hear.
We need to make sure that we're taking care of the biology. Yeah, take care of the biology. So, there are so many changes that happen in the perimenopause and menopause transition, whether it's the weight gain and they're feeling discomfort about the changes in their body, whether it's that they're so tired because they're having hot flashes and night sweats that's disturbing their sleep, and they're going to choose sleep every day over sex when you're saving it for the end of the day,
Yeah.
So they're not feeling themselves. And this is one of the most common complaints that I hear, is that I don't feel myself. Mm-hmm. So when women are not feeling themselves, they don't show up the same way sexually. They don't have the energy for it. They don't feel sexy. They don't want anybody to touch them. They're just over it. They sometimes don't even like themselves, right? And if you add the body image that goes along with it, you add painful, dry vagina and urinary urgency and frequency. There's a lot of feelings around what's going on with their bodies. And now if they have this persistent low desire, low arousal, regardless of stimuli, then that's hypoactive sexual desire disorder. And then we have to address that. And we do have medications to treat it. But a lot of times we have to look at, what were we taught about sex? What does our relationship look like? Because I can give you all the estrogen in the world, but I can't fix a bad relationship.
Yeah. Or the trauma around sex.
Or past, right. Or past trauma. Like, these are things that we cannot isolate, and they really have to be taken into consideration. Is there resentment there that's keeping them from wanting sex? Or is the partner awfully needy? It all kind of interplays. And so a lot of times my approach is, let's go to counseling. counseling. Let's try sex therapy. Let's read Dr. Kelly Casperson's book, You Are Not Broken. Stop shooting all over your sex life. And let's get you on proper hormone therapy to address the biology of what's going on. Because like I said, if we get the hot flashes and the night sweats under control and we're getting more solid sleep, we have more energy, we may be back in the gym, we may be eating better, feeling better, looking at things better. And, that partner who just, just them chewing or breathing or snoring in the same room makes her homicidal.
Yeah, exactly.
If we don't address the hormones, right? So it's so multifaceted. And I just like to kind of take it step by step with patients, because it's never just a one and done. I fixed your sex drive, right? Now, if we do have I want to back up. Vaginal estrogen. Okay. Vaginal estrogen is safe for everybody and every body. Okay. So it is safe whether you've had breast cancer. There is not an increase in incidence of breast cancer or mortality from breast cancer using vaginal estrogen in the typical dosing. It is local, intimate skin therapy. And as we age, that intimate skin, the mucosa starts to thin. We start to lose the folds. The vagina becomes more rigid, more dry, more brittle, for lack of a better phrasing.
God bless us all.
So unfair.
It's so unfair, right? And yet this man has an external organ, right? Yeah. The vagina is an internal organ. The vulva start to change. The vulva even start to thin, and we can start getting adhesions, and all this creates pain and discomfort. Sometimes women will get hormonally mediated vestibulitis. So the opening of the vagina is painful, and we have to address these changes, but it generally takes about 8 to 12 weeks on proper dosage for us to see the effects. So it doesn't happen overnight. Mm-hmm. So don't be like, oh, she's got her estrogen, we're good.
Yeah.
Give her some time. The body takes time. Estrogen deficiency affects the entire body, the brain, our bones, our joints, our moods, everything. Mm-hmm. So we cannot ignore the fact that someone who's had postpartum depression or a history of depression are more likely to have a depressive episode in perimenopause and menopause as we start having these erratic fluctuations in our hormones, and that affects our sex drive, right? If medical conditions present in midlife and we're dealing with that affects their sex drive and how they think about themselves and their body and life and relationship. And then you add long-term committed relationships. It is very common that women have a responsive desire, meaning they're not throwing the party, they're not sending out the invitation. They might put on the heels and go reluctantly, but then they're there and they have a good time. They're like, oh, this is great. We should do this more often. But then it just leaves them. They never think about it again.
Yeah.
They're not sending out the invitations. So this is what we call a responsive desire. And that's very common in a long-term committed relationship. And so I often encourage spouses, but it's hard when they're not coming to the office many times. But when they do, I encourage them, if you help take off the workload of the home, if you do things together that create intimacy, whether it's just sitting and having a conversation or doing an activity together or, massaging her back without an alternative motive,
yes.
all these things build intimacy where she gets in the mood because it's that responsive desire. Mm-hmm. It's not like Hollywood and porn where we see this, the eyes lock and we're in the mood. Right. That doesn't work for women. I love the analogy of you're going on vacation, and to get into vacation mode, you need a plane ride and a Mai Tai, to get into vacation mode. Women are more like, they're not a microwave. They're more like a crock pot, right? Yeah. We've got to spend some time
slow cooking,
building up that and bringing novelty, because our brain loves novelty. Mm-hmm. Okay. So the two important things before we even talk about what medications we can use for low persistent sexual desire, I want to make sure that we know that we don't desire things that hurt. So if we have genitourinary syndrome of menopause, we have to address that. And it takes at least 8 to 12 weeks for us to see effect. Now, some people 2 weeks in are just so excited. And many times when we fix the dry, painful vagina, the low sex drive is gone. I mean, I had somebody come in this week, 70s, and desperate to still have a good sex drive with her spouse, and having all the GSM symptoms. Treat it with vaginal estrogen, and all of a sudden she is excited. She's feeling more aroused. It's just so much more exciting for them because it doesn't hurt.
Excellent.
Right?
I want
So
to,
this
can I
does
say
happen.
something? I'm sorry to interrupt you. You made this comment, and I feel like I hear this from time to time. You made this comment that it's not like that. You said something about like, it's not like the porn or the rom-com kind of thing where you lock eyes and it's just everybody's stripping their clothes off and having this amazing sex and their bodies look all beautiful.
Right.
I think that, well, let me speak for some of my clients. Some of my clients have been guilty of measuring themselves against that picture, not just the men, not just men going, well, I thought it was supposed to be like this. I thought you were getting instantly turned on by my physique. But I hear women saying, that's not what my sex life looks like. Therefore, I must be problematic. There must be an issue.
No. And women often take on, if they have a lower desire or a higher desire, they think they're the problem and they need to be fixed.
Yes.
So, yes, this has done an absolute disservice to us as women, because it's not like that, and women, it oftentimes takes, almost 20 minutes of stimulation before they may orgasm, right? And it is the rare unicorn who's going to orgasm from penetrative sex.
Right.
So we have to pay attention to the clitoris, men. I need to show everybody my clitoris model. I don't have it with me today, but
you need a travel one. You need a travel.
I need a travel clitoris. She is equivalent to the male penis. She has 10,000 nerve endings, and her whole purpose is for pleasure. And, she takes a deep dive and actually has two little legs that go on, behind the vulva. So this is why external stimulation feels so good to women. It's erectile tissue. So we have to pay attention to the clitoris in order to bring arousal. And so we have to have sex worth having, right?
Absolutely.
So women don't fake orgasms. It's not serving anyone, because if we're just moaning, you're like, oh, it must feel good. And, they're going to keep doing the same thing.
Yeah, we're having good sex, apparently. Right. Mm-hmm.
Right. And so often we're all having sex, but not talking about it, right? And so I think with clothes on is the best time to have a conversation about sex, not when we're in the moment, but I heard this on a podcast, or I read this in a book, or I saw this article. I would love for us to have a great sex life. What do you think? Just opening the door for conversation, I think, makes a big difference in that long-term committed relationship, especially when we're trying to figure out, well, like, what's fun and good for us, because we've been doing the same thing for 20 years.
Mm-hmm. Right.
So I think I said the brain loves novelty, and we can't compare ourselves to what we see on TV because it's just make-believe.
It is. Please. It's fiction.
It's absolute fiction. Just forget it.
Yes.
Well, one of the things you said, Dr. Moyers, that I really connected with is, and it comes up a lot. I'm actually in the middle of working on a certification that's called Integrative Sex and Couples Therapy. And so it really is specifically to be very skilled at talking to couples through this issue about sex, and however it rears its head. And one of the things, and I'm really careful as to what I bring in because I'm not all the way done with the course yet. But one of the things I do talk about, because I feel like I understand it very well, is they call it like scheduling a sex date. And that doesn't mean a date that we're going to have sex. That means we're scheduling a time that's going to work for us, that maybe the kids are at grandma's, or we can hire a babysitter or whatever. And that means reintegrating these things that you were talking about, right? And how do we do that? Like, how do we learn that? And they even give an example of, one night the sex date is you give her a massage and that's it. And you roll over and you go to bed. No ulterior motive. And the next week on the sex date, you get a massage and you roll over and you go to bed, and that's literally it, and then the next week, maybe you give a massage and you're allowed to be a little frisky here and there, and that's it, so it's this gradual reintroduction. Because also, and I would love to hear what your patients say about this, is if this has been going on for a long time, and I know my own personal journey is, it took me about 2 years of problems before I got to you and was like, oh, thank God, someone is listening to me. And I feel like I'm a very sexual person, like kind of have been my whole life. And I was like, nah, Never, I don't even care if I ever do it again.
Take it or leave it. Yeah,
Good.
right.
But for about 2 years, this had been happening. So most of the time, this is going on for a really long time before people seek help, right? Or they understand what's happening. So with that, taking that into account, what it creates very frequently is sexless marriages.
Sure.
Right. And they identify, I mean, like, they in my course, a sexless marriage is less than 4 times. It's 4 times a year or less.
Mm-hmm.
I would say that's very infrequent, but but if you've not had sex in 3 months, 4 months, 6 months, it's weird.
Mm-hmm.
We've made sex weird. So that idea of reintegrating, it's like, what do you hear? I'm just curious. What do you hear from patients in that regard, and kind of what advice would you give that from like the medical side of things?
So a couple of things. The most common reason that women stop having sex is because it hurts or lack of a partner, right? So I just saw somebody today, they haven't had sex for several years now, and they stopped because it hurt. And then the husband got a cancer diagnosis and, had to undergo treatment for that. And they just haven't tried again. So yeah, after a couple of years, it's like, oh, this would be awkward. It's also like you're a virgin again, you're doing this all over again for the first time. And so there's a couple of things, especially when we're dealing with addressing the genitourinary syndrome of menopause, and they're getting their vaginal estrogen on board, and they're starting to not notice as much dryness, even just with like wiping, they sometimes notice fissures and it's tearing. But if they're wanting to build confidence before they bring a partner into this interplay, what I often recommend is a menopause massager. So it's a little OnePlus makes this vibrator that they call a menopause massager. So it's also a little less intimidating to some in that age category, right? And it heats and it vibrates. And so they can bring blood flow to the pelvis. And it has 2 different sizes on, one side is a little bit larger than the other side. And they can practice penetration once they've brought blood flow to the area.
Wow.
To build confidence before bringing, or they can do it partnered, either way. But to build that confidence to know, oh, it doesn't hurt and I can tolerate this. And maybe it brings a little fun and novelty to a coupled experience, right? So reintroducing that, I do think there's definitely that psychological component, right? Where we have to have conversations, what feels good, what doesn't feel good, how do we want to approach this? It's okay if we don't have penetrative sex. That's not always going to be the end goal, right? So talk about what the end goal is and what are other opportunities or other ways to be intimate to create pleasure for each individual.
What happens when that is the end goal? What happens when that is the end goal for you? In my experience, and I'm kind of going through my Rolodex of clients historically, not just actually, none of these examples are current. But when there's a couple and the end goal, the husband says, no, penetration is the goal, is the thing, because that's what makes me feel the closest to my wife. That's what I want. Anything else isn't working for him. What's that? What do we need to say around that?
Well, I do think that there are ways to achieve that, right? So it really depends on what's going on with the female patient, with the vulva owner. Okay.
Well, the vulva owner is saying that is actually not desirable for her. I'm sorry, I didn't clarify that. He wants the penetration, and she's backing off. She's kind of like, some cases have said because it hurts. And there's a little bit of a lack of understanding from the husband, but I'm being so gentle. But we've tried all of these reasons.
Yeah. Right. But there's so many things that can be done for that, right? Well, first of all, there's multiple ways to give vaginal estrogen. It's not just a messy cream. There's a tablet, there's a suppository, there's a ring, there's a vaginal DHEA suppository. That's really great for postmenopausal women who have painful sex, because it's a precursor to estrogen and testosterone, and we have a lot of testosterone receptors at that vestibule. So I think I mentioned earlier the vestibulitis, so the inflammation that can happen because of hormonal changes at the opening of the vagina. A lot of times that's not addressed. Well, if it hurts at entry, it's hard to get past anything, right? But then if it's dry and painful and still sandpaper, we have to know exactly what's going on. And not a lot of people are doing sexual medicine well. Okay. We don't learn a lot about it in in OB/GYN residency, right? I mean, I didn't even realize the detail of the clitoris. I mean, and I'm an OB/GYN who operates in the pelvis, which is kind of ridiculous. It wasn't until I got involved in the International Society for the Study of Women's Sexual Health that I even had a clue.
Interesting.
So
that's interesting all by itself, but continue.
Right. So if you need if you need somebody who is sex med, literate, then I would probably go to ishwish.org. That's International Society for the Study of Women's Sexual Health, ISSWSH.org, because you can actually look up by zip code or by state, because you can see people via telehealth, to find somebody in your area to help you, because that's such an important piece to address. Well, what is it? And that's, something that I think patients like in my office that I will just say it like it is. And so we're going to have some detailed conversations about what is it that really is the barrier. For some people, they're really bothered by their weight gain. Mm-hmm. For some people, they're really bothered by the dry, painful vagina, and that needs to be fixed, right? Mm-hmm. But then we have to build confidence because the pain has been there for so long, right? Or if there's a vulvar disorder where there's scarring, like lichen sclerosis or something like that, that's going to be chronic and progressive, we have to get on an appropriate maintenance treatment. We may need a vaginal dilator to allow for penetrative sex. There's, some studies about using a vaginal laser to allow that. And we do have Mona Lisa Touch, a vaginal laser in our office now, that has created a lot of more comfort and enjoyment for patients who have some of those restrictions. So there's a lot to it, right? So it's really about what is the vulva owner's comfort level with that, and if we have addressed the discomfort, is it something that she's got a mental block about it? Yeah. Or is off the table for her, not enjoyable or not possible, etc. So then we have to help our male partners come to terms with what is another alternative to allowing them to feel close and to have pleasure and to feel that intimacy.
Right. Yeah. I like that. And I appreciate that you have this I like that you said, I just shoot straight. I speak directly with my patients, because that allows conversation to happen that probably has felt awkward, even in the married, even with the couple. Like, that's a hard conversation to have about, because like we said, emotions and ego and all of this gets involved when it really is just physical things happening within our container, as I like to call our bodies. So I have told my clients, and I know Heather has too, I had a client not but a couple of weeks ago who was really in tears over her, how she's been feeling.
When you have patients that get to you and you've done all the things, you've done the estrogen, you've done the hormones, we've worked through the physical part of it, and they're still reporting, I'm irritable, I don't feel good, I have no motivation, I have no energy, When does it get to a point where you then say, okay, you know what, sis, we may have done all we can do here. How about seeing a therapist, right? Like, what is for you, how do you kind of get to that place in your journey with them through the hormone therapy, through the physical health part of things, to where you say, okay, I think we've gotten to a place where then we're at that mental block, or something else is going on that.
Yeah. So before we go there, can we talk about the medications to address low sexual desire? Because some of them also help with a lot of that. So we have a couple of medications for low sexual desire. One is testosterone, and we've always thought of testosterone as a male hormone, but it is a human hormone. And women produce plenty of testosterone. Our ovaries and adrenal glands produce testosterone. Our testosterone only decreases by about 50% as we go into menopause. From our 20s, it kind of declines. So it's not this rapid drop off like we see in estrogen. Yeah. Testosterone is indicated for low sexual desire in women. Postmenopausal specifically is where, the studies consistently show that it works. And does it work for everybody? No. The goal is a female physiologic range. Unfortunately, what I see so often is women getting pelleted and having these super therapeutic doses of testosterone and then having adverse effects, and you can't take it back. So we have a consensus statement, a global consensus statement, and a practice guideline from International Society for the Study of Women's Sexual Health in replacing testosterone, and with the goal of keeping women in a female physiologic range, like a premenopausal female physiologic range. What was it before?
Right.
And a lot of times women report that helps with their drive, their mental clarity, their mood. So that can be very helpful. I generally have patients trial it. We use 1/10 of the male dose because we don't have an FDA approved female version in the United States for about 6 months. Do we see an improvement? Are we dosing in a physiologic range? And for some, that's the ticket.
Okay.
For others, we have Addyi, which is fulbanserin. It is a drug that works on the central nervous system, and it's taken at bedtime because there can be some drowsiness with it. It's taken every day. It's the little pink pill. Thank God we have one for women now. And again, you take it for at least 2 months consistently for us to see an improvement in sexual desire, and the response rate is around 60%. And so, it's not 50-50. It's a little bit better than that. But again, we're all unique human beings in how we process medications and how we react, et cetera. So this is acting on serotonin, so acting on our brain, similar to testosterone, right? Our brain is our largest sex organ, which is why I incorporate therapy early in the process if we're having a lot of barriers. Our last drug for female sexual desire is Vyleesi. Vyleesi is a injectable. And so this one you can use up to 8 times a month, and it's like a little EpiPen, and you use it about 45 minutes prior to sexual activity. Common side effect is nausea. For some people, it works fabulous. Now that we have, GLP-1s are so popular, some people don't have a problem injecting themselves. But what I find with most female patients is that if they don't have a sexual desire, they certainly don't desire to poke themselves to get a desire.
That makes sense
on
to me.
demand. However, if it is that you're scheduling sex, as you talked about, because a lot of times what I address with patients is, so first of all patients who come into my office, they're filling out their questionnaire. And part of my intake questionnaire is this short little 5 questions about their sexual desire. Okay. And so in that, we're looking at, well, what do you think some barriers are? So, what I like to talk to patients about is, well, what is a good sex life look like to you?
Yeah.
What would success look like for you?
Great question. That's a great question.
And so for some people, it's, well, I want to be the one to initiate sex at least once a week.
Mm-hmm.
Okay. So maybe this is when you schedule your sexy night and you're the one who's going to initiate. This is when you might be more comfortable using your Vyleesi, knowing that you're anticipating sexy night and that it's going to last a good 12 hours or so. So it's great for morning sex as well. You could, use it the night before. So there are situations where it might work great for patients and it works on a different pathway. So you could use both. But then, of course, we get into the cost of, I'm using this one, and they get to be kind of expensive. But we have to use the manufacturer coupon to get those approved. All to say that there are additional options for treating sexual desire other than just like, I've thrown my hands up, I can't do anything else with you. If I fix your GSM and there's nothing else, I don't know what to do. So we definitely have things to address that, whether it's addressing the systemic hormones, the hot flushes, the night sweats, the disturbed sleep, or the genitourinary symptoms, the dry vagina, painful vagina, need to pee all the time. And then if it's a persistent low desire, we have these medications to address that low desire. But like you were saying, Heather, I love to incorporate therapy, whether it's specifically sex therapy or just cognitive behavioral therapy early on, especially if there's past trauma or resentment, or I'm hearing some barriers to that desire for whatever reason, because it is multifaceted. So I'm oftentimes handing out this brochure and this brochure. And Rosie is a fabulous app, ROSY, designed by an OBGYN. It is all about female sexual health. It is a great resource. They even have like little erotic stories in there. So if patients wanted to listen from their phone to something, there's so much free content in there. If you look at their menopause content, yours truly helped to design that.
Oh, nice.
So there's so much information in there for patients. And that's a great one that I love them to just, if they don't have time to read or they don't want to be caught reading a smutty book, maybe this is a great way to introduce some erotica as they're entering into
Love it.
sexy night or scheduled sex. Or if it's just their day, they mentally have said, Tuesdays are going to be my day. I'm going to listen to erotic on the Rosie app, so it's all safe.
Yeah.
On my way home, I can pick my level of spice, on the way home from work, right? So that she's already setting her mind to be prepared. So I think that it's also multifaceted. It's never just one thing.
Absolutely.
And whenever we use this multidisciplinary approach for patients, it makes such a huge difference. But to your point, Beth, I think it's really important for us to bring the male partner into the conversation and help them to understand, because let's be honest, we're from different planets. Men and women are from different planets,
Mars and Venus.
And you have a same-sex couple, like they just get it so much easier. Men and women are from different planets.
True. We send so many of our beautiful clients, our beautiful women, to you because we know that they will be just hugged and cared for and educated and validated. And thank you for all the good work you do with women. And
right back at you.
We applaud you, and we're so honored to be partners in crime with you and work. So thanks so much, Heather. Thank you for your time. Definitely go find Dr. Carolyn Moyers at her website for Sky Women's Health, as well as Heather and I at vervewell.org. We are here to be your champion.